Good morning, everyone. We'll see if this mic works okay. Is it better there? Yeah. Is that okay for sound? Wonderful. Welcome, everyone. Thank you for waking up early on day 4 of the conference. Do we just have a handheld mic, perhaps? Is it better? Thanks so much for coming to this session on blood-based self-testing. We've heard a lot at this conference about the importance of choice in prevention. We haven't heard quite as much yet about the importance of choice in testing programs and what that means for giving people choices and making sure we can reach those at the last mile who may have very different preferences. And the Global Fund and many partners have been working very hard on diversity of choice and self-testing over the last few years. And it's been quite a journey. It's been wonderful to see all of the governments and partners coming together and work through all of the many challenges and bringing new products to market and understanding how they fit into their different contexts. So we have a wonderful session for you here today. I won't talk very long because there's others on this panel and our co-chairs who have much more experience in this than I do. So I'm very happy to first introduce the two chairs of this session. Siobhan Crowley, who's the head of HIV at the Global Fund, and Karen Hatzold, who's the director of HIV and TB at PSI. Both of who've really been leading the charge for expanding the choices of different types of self-tests in the market for the benefit of the many people who need access to testing. So I'm going to start by handing over to Siobhan for giving us a few words about what blood-based self-testing looks like in the Global Fund programs.
Good morning, everyone. I daren't touch the microphone unless it gets touchy again. Lovely to see you all again. And this session, I think we're looking forward to this discussion and hearing from the countries. As you've heard in other sessions, we've seen the role and the power and the place of HIV self-testing become much more dominant in the recent years. And I think from our perspective, we see it as a very important part of the testing choice that countries have, and figuring out exactly which tests, the nature of the tests, and where you place it in your testing strategies is what countries have been grappling with. We, as the Global Fund, we sort of represent around 25% of the global marketplace for low and middle income countries in HIV self-tests. We spend across the entire HIV, TB, malaria portfolio, and notwithstanding the fact we don't have a great TB rapid diagnostic, but so mainly for malaria and HIV, we buy about 1.1 billion tests per annum, and we spend about $500 million each annum on RDTs. So for HIV tests, last year that was we spent about half of that money on HIV tests. Sadly, we only get about 25% of those RDTs, actually HIV RDTs, because they are very much more expensive still. We also, at this point in time, mainly for the HIV self-test, which is about only 16.2 million, we've been having what we call a matching fund to accelerate the uptake of HIV self-tests in the last cycle. That matching fund was a donation to the Global Fund by CIF and was made available to some countries for them to match from the funds they get from their allocation, a kind of an additional incentive to really help the HIV self-testing take off. Those 4 countries all had a lot more room to take risks and try new things with self-tests. And we saw those countries sort of accelerate more. And we're going to hear from some of those countries. We've ended up spending about 16.2 billion self-tests across the portfolio the last cycle. And it's around 10% of our RDTs at this point in time. However, at this point in time, there may be oral tests. We have had some countries move to using blood-based tests, and there's some early information that suggests that in some, well, we know that the price is likely to be a bit lower generally for a blood-based test. We also know that there is some information suggesting slightly better performance characteristics. But it's a matter of preference, to be honest, from what we hear about who wants to use what where. And I think that's what we'd quite like to hear from the countries today. So as we're understanding how and which self-tests we're going to use, how they're going to be used, facility-based, community-based, those things, that's what we want this session to be looking at. And we want this session to explore how the countries have been navigating this and the introduction specifically of the blood-based tests, what they've learned and what they would like to share with you. So that's sort of roughly how we're going to run the sessions. We're going to start with a brief overview of the HIV self-testing programs in Nigeria and Uganda. Our colleagues are here with us today. They are then going to be asked a few questions by Karen, my co-chair, and then we're hoping to have a little bit of time at the end of the session so that you can also get a chance to ask questions of our panelists. So less time for us to speak and time for us to hear from the countries and their experiences doing this. Karen, I'll let you introduce the panel.
Yeah. Before I introduce the panel, just a few words to the work that we've done under Unity STAR, or the introduction of blood-based products. As you know, STAR was sort of the largest project on research and implementation on HIV self-testing. And I think the panelists that are on this panel will speak about their experience of introducing this. Just to speak a bit more about this, when we started with STAR, we introduced the first pre-qualified test kits. This was an oral fluid test. And only 2 years later, the first blood-based product was introduced to the market through the pre-qualification WHO. And there was a price difference between the oral fluid tests and the blood-based products. And through the market intervention that we led, also through the STAR initiative, we were able to reduce the price of these blood-based products at the same level to the oral fluid tests. That's just to say again as another introduction to this theme. So we have now equal prices for slightly lower prices for the blood-based products. But it took us because we introduced the oral fluid test initially in all those countries that were supported by STAR as the early adopter countries. People got really used to the oral fluid test, and self-testing was equal to oral fluid tests. So it took us a bit more time actually to introduce those blood-based products. And again, our panelists will be speaking about how we were overcoming these barriers, the structural barriers, the policy barriers, and the implementation barriers to get the blood-based HIV self-test kits so onto the market through the different distribution models, including also the private sector. So with no further words, I'm introducing to you the panelists, and I would like to invite them to come up to the panel, to this podium, please. So there's Dr. Data. She's the Deputy Director and Head of Prevention at NASCOP, in the Ministry of Health in Nigeria. I would like to call upon Mr. Jeffrey Tassi. He's the Team Lead for HIV testing services in Uganda at the Ministry of Health. And from our implementers, I would like to call upon Peter Ogoni. He's the Program Director at Population Services International in Uganda. And Joshua Ashioko from FHI 360 in Nigeria, who is leading the PR as well for HIV prevention and testing under the Global Fund. Okay, thank you so much. My first question actually goes to, from the policy perspective and overcoming structural barriers, goes to Dr. Dada. In the Nigerian context, what were the major key policy and regulatory and structural barriers to overcome to introduce the blood-based products, and how did you overcome them?
Thank you very much. For Nigeria, from the inception of the introduction of the HIV self-test kits, that was in 2020, we had introduced the oral-based and the blood-based into the guidelines. And even in our national operational guideline on HIV self-test, this was being introduced, the implementation, the framework on how it will be implemented is in that document. So from inception, blood-based was not an issue. So when we started with the oral, people accepted it. But so for policy-wise, there was no issue. There was no issue with the government and with the people. However, what happened was that there was this contemplation on if it's blood, will people accept it? So people were like, will it work? Will it not work? And that was one of the delays we had in bringing in the blood base, because the partners, people were not too sure of what will happen if they bring in the blood-based test kit and it's left there wasted. Nobody's using it. But so what we did was we now had to do a lot of sensitization and engagement with the people. We had meetings, we had symposium talking about the blood base, the effectiveness, and people feared was allayed, and a lot of people came for the symposium. We had the stakeholders, even the manufacturers were part of it, the IPs were part of it, the private sector, public, they were all part of it. So from this symposium sensitization, a lot of work was done, even with our partners, JPIGO, Abbott, they were all there on this, and it really helped. This really helped a lot. So people had started accepting the blood base. And what we did a study with the World for Blood Test in 2 states in the country last year. And that was a past project by CHI. In collaboration, we worked with them, and we discovered that a lot of people really accepted, about, I think 92% accepted the blood base in these 2 states. So there's intention of going further to assess more states on the accessibility, and even the use. They said it was easy for them to use the blood-based test kit. So it's like the flow was not too it was not too problematic for us. But the sensitization, the symposiums, the advocacy to all those even the manufacturers, they now started requesting for the blood-based test kits, and a lot of the pharmacy, the PPMVs, the community pharmacies, they were now requesting for blood-based, not only the oral. They have a lot of it in the market. Thank you. Approved test kits.
Mr. Tassi, from the Uganda perspective, what do you want to add with regards to overcoming policy and also specifically regulatory and registration issues with regards to blood-based products, and how has that been handled in Uganda?
Thank you very much. So for Uganda, our experience is not so different from Nigeria, but what I can say is that for us, right from the start, when we developed our HIV self-testing guidelines, we made the guidelines open. Of course, when HIV self-testing started in Uganda, the oral quick kits, that's by OraSure, was the face of HIV self-testing. And HIV self-testing for most people is defined as oral quick, yeah? So we made the guidelines open from the word go, because we knew at some point the blood-based products would be there. I think that time it was only IST that was WHO qualified, and apart from the HTS, the self-testing guidelines or HTS guidelines, we also have a very beautiful protocol, entry protocol for diagnostics in the country, working with all the labs and our department of the our lab department of the Ministry of Health. So we have that beautiful protocol. The challenge then, like I mentioned yesterday in the other session, was that registration would take 6 months to 1 year. So thanks to WHO, because the collaborative registration process now, after going through the training with the NDA and many other stakeholders, within 3 months, the products are registered. So we used our entry protocol to have the products validated, different manufacturers requested. We had the products validated in the lab, but also in the field. Bottom line, WHO pre-qualification. Then we do the internal validation in country. We also take it to the field for feasibility, acceptability. What are the users telling us about the product? Okay, is there anything to improve? Are the SOPs clear? Are the illustrations clear? Can the product really be used? Can it produce the same result like it did in the lab, which is a controlled environment? Yeah. And then, of course, the other thing you could call a barrier that's not just for blood-based was also the issue of access in terms of the private sector markets, especially the drug shops, the supermarket, and other non-medical outlets. So the challenge initially was that self-testing was the product was so medicalized that you have to access it in a hospital, in a clinic, in a pharmacy. So we've been working with the NDA, the National Drug Authority in Uganda, the equivalent of FDA in the US, to ensure that the products are allowed. First of all, you can access in the supermarket and work with the OraSure team to put stalls in supermarkets so that people, as they're shopping around, they can just pick a product. And so the blood-based product. So accessibility, we've been working on that with NDA. So you can get on the online pharmacy because initially also we did not have regulation for or against online pharmacy, but we're trying to make sure that that is also protected so that nobody doesn't come later and say, hey, you cannot procure an HIV self-test using the online pharmacy. And then finally, our biggest competitor, especially in terms of quality, were the unapproved products. Uganda, like any other country, through our porous borders, so many products coming. And not just for HIV, by the way. We have a problem across many RDTs: HIV, syphilis, malaria, hepatitis. Others are just branded HIV, syphilis, hepatitis, and you don't even know where they come from. You don't know who manufactured it. So like any other African country, our borders are quite porous. So our market was really flooded with the unapproved products. And 99% of these, if not all, are actually blood-based. So we thought if we open the market and make more blood-based products coming that are WHO pre-qualified and probably affordable, because the others go for $1, $2, $1 actually, even less than $1, the unapproved products. So we thought that if we open the markets, have more qualified products come in, and probably the prices go down a little bit, then these other fake products will, by default, actually, and we've seen it, by default, they will just go away. But also we are working with NDA to ensure that there is enforcement. We do post-market surveillance at every quarter. We go to some outlets. Some of those fake products are picked up, and the suppliers are told if they bring them again, then they should be arrested. Yeah, so it's not really, you can't say one thing or two or three things have enabled us, but it's a whole environment. Yeah, it's a whole environment, but also working with stakeholders, coordinating them, and making sure that we move together, especially to ensure that Ugandans are protected, they access the products, but also the products are affordable and the products are safe for everyone.
Thank you so much. Very interesting perspective from Uganda, where the enabling environment for the introduction of HIV self-testing was really, really very good. We have good examples of using WHO CRP for the fast-track registration of these products. We have policy and regulations, and that really was a very good enabling environment. From the program perspective and for the implementation, now understanding supply side and demand side interventions that need to be there, and the research firms that went into understanding how people would access the testing service and how we introduce the blood-based products in this mix. What can you say in terms of the preparation for the implementation, Peter, in Uganda, what needed to be put in place from the supply side as well as from the demand side?
Thank you, and good morning, everyone. So for Uganda, in terms of preparing for implementation, looking at both the supply side and demand side, first of all, MOH leadership was very important, meaning that MOH has an HIV/AIDS task force, which basically initially was focusing, of course, as Tassi has mentioned, on OraQuick and OraSure. But eventually, any other player who comes in. The interesting thing about this committee or task force is that it includes all the players. It's not just government, it's non-government, it's commercial sector. So we have the distributors in there. And that means that as you go in, you have a group of people who are working towards the same objectives. Now, the work that we did, supported by CIF, was focused on building out the private sector. So the first thing was to understand the consumer journey. And understanding the consumer journey went through a human-centered design approach. And in this, we're able to identify the issues, both the enablers and the barriers from the attract up to the advocacy level. And what was clear, of course, the private sector was having what I would call expensive products, $3, $4. So the first thing was to say, who is our target audience? Who can pay this money? Because that's the reality. We could not assume that everyone could afford these quality assured products. So that meant that we had to talk to older men, people with disposable income, and in Uganda, the private sector that stocks these what I would call expensive products are the pharmacies. So by extension, you're looking at people who go to pharmacies. So in a way, it's limiting, but that's part of the reality. But as Geoffrey has said, the question around, can we get drug shops involved? But of course, prices need to go down. If prices do not go down, then drug shops cannot, because the people who buy their product, they're going to be buying cheaper kits. So very importantly, understanding the consumer. And after understanding the consumer, we now needed to activate the supply, because they were used to having the product, but not a lot of demand creation. It's not that it wasn't existing, but it wasn't. We had to activate, we did physical activations at the pharmacies. But after learning that, okay, the people may not have time to listen to you there, we needed to go out and find the people in the community. So we went to corporate affairs. Again, remember the target audience, those who can afford. So if there was a corporate event, we went there. And of course, there's a relationship to HIV incidents and so on, because the older men generally in Uganda have they are the ones who have not been identified. So whereas it's not very related, but at least you're still not going to the general public. You're looking at these events whereby you're going to identify these populations who can afford to go to pharmacies. And these same populations access online services. I know the question might be, online, who has a phone? So if we remember, the target audience is those who can afford. They are the ones who can access online. So we use the influencers to get to them, for them to be able to talk to them, and we got some interesting results. We had an average sales at the beginning in about 30 pharmacies of about 200 a month. By the end, we had about 1,300 on average. So it showed that you could actually create this growth. We also started opening up the online channel. Again, when we look at the target audience, the online channel for the younger people, they're also interested. There's a lot of interaction. Some other elements is around the partnerships. We need to think about care along the journey. Once I test, if I want to know more about the results, so we collaborated with Baylor and the Ministry of Health call line. And these are, they have a call line, and we promoted it Before they used to get some calls, but again, the calls grew exponentially after that. And this helped in terms of follow-up care, if you may, in terms of linkage. What do the results mean? So we're getting a lot of questions around what are these results? What do they mean to me? So even though the instructions are there in the packaging and so on, there's still interest, and calls are coming at all times of the day and so on. So it's important to set up linkages with, in this case, it's private sector, but the people doing this extra work are actually not private sector. So private sector, interestingly, we had joint activations with them, and they accepted to put stickers with this additional information on their kits to enable to create that level of linkage. The final point, or the final few points, are the opportunities for bundling. If we think about self-care, self-care is not, I mean, HIV self-testing is one thing, but then there's additional products that are related to it. So for example, if someone comes in for a pregnancy test, so most likely they've had unprotected sex, or if they have come in for a condom, most likely they are going to have sex. So we bundle them by putting these products together and encouraging the pharmacists to talk about them, to be able to say, when someone is buying, oh, you want condoms, you're showing them there's also an HIV self-test, and the other way around. This was a work in progress and needed more opportunity to grow. But those are the ideas that we put together that were building out the private sector from this point of view. Then as you do demand in the private sector, collaborate with the distributors to ensure that they stock, because at some point we ran out of stock. So they were used to bringing not a lot of stock for private sector because the demand was not that much. So once you build it out, have you, and maybe that was an oversight on our side, have you actually had that conversation that you expect some growth to happen? So at some point they ran out and then it had to be replenished. So those, I believe, are the key points in terms of implementation. Thank you.
Perhaps just one follow-up question on this, because you might not have answered completely my question, because we were interested in the blood-based self-test kits. Did you see with your campaigns, running specifically for the private sector, did you see any differences in uptake of blood-based against oral fluid tests? I think you have an oversight over the private sector. Because our campaigns were really agnostic actually to the self-test, isn't it? It was not specifically calling out certain brands or blood-based or oral fluid tests. Can you speak a bit about the demand and what has been created and what the uptake was of these tests according to oral fluid and blood-based tests?
So when we started out, the context is that, as Geoffrey has said, there's a lot of the professional kits, people have been using them for self-testing basically. And these are blood-based professional kits. So in terms of demand, if you ask me, the demand is there. Because when we built out the M&D system in the pharmacies, you could clearly see that the quality assured HIV kits were actually a very small proportion. There were maybe 20% or less than 10 to 20%. The rest were actually the non-quality assured. So in terms of demand for blood-based, it gave you a vision of what can be. But as Karen has said, we promoted both. The big issue is going to always be price. Yeah, when we had an opportunity for Chai, I believe, Chai Path, I believe, had a subsidized Mylan kit. This, because it was subsidized, the price was low, it also took off at a certain point at the tail end of the project. So there was definitely a pickup for both blood-based, because our campaign was agnostic. It was basically focusing on the quality assured kits, and therefore there was pickup. So there was, if the price is right, blood-based kits will not have a challenge in the market, at least, because currently, if you ask me, that's what most people are using, even though they are not quality assured. They are just going for the price element.
Very interesting perspective. Going back to Nigeria again, FHI 360, you were really preparing for the rollout on larger scale-up of self-testing, really under the Global Fund investment. Can you speak about the steps that you have taken to prepare for this large scale of self-test kits distribution, as well as in the context of blood-based products, but also generally? Thank you.
Thank you very much for the question. Before I start, let me just first of all appreciate and acknowledge the Global Fund for the investment in HIV self-testing in Nigeria. Over the past 2 years, we have had, for FHI 360 in the Global Fund projects, we have had over 640,000 test kits done, 640,000, and we've had a significant number of positives from those tests, and outcomes from those testing has helped us to improve our prevention packages as well as our care and treatment packages. So many thanks to Global Fund and CIF for that support. And recently we had over 240,000 blood-based test kits delivered to FHI 360 in the country. So that's really important to recognize that support. Now, back to the question, one of the things we observed in planning large-scale blood-based testing is it's very important is the role of the governments in coordination. Now, in Nigeria, you have a lot of quite a number of partners that work on HIV, especially when it comes to HIV prevention, like HIV self-testing. We have FHI 360 doing that. We also have other partners like GPIBO, we have CHI, we have IHV and other partners. So the role of the government is extremely important, and NASCAP has done a great job in being able to ensure that all partners have a platform, a level platform to be able to harmonize our interventions. So that's important. So there's no conflicting implementation. And of course, also with respect to reporting lines, really important that the government takes center stage. Then we have the planning. Planning is really key when you are implementing the blood-based testing. In planning, we consider the end users at the center of our planning. It's really important. We have meetings with the stakeholders that are the end users. We ensure that we sit on the same table. We share the same objectives. We identify where we can or how we can be able to effectively roll out self-testing among the population. In our environment, we consider a lot the partners of persons who live with HIV. We consider key population. We consider men and other groups as very important end users and target population. So bringing these groups together, understanding the needs, doing the feasibility study, needs analysis is really important for you to have a very robust implementation planning stage. So we also ensure that the budgeting for the product is appropriate to be able to ensure that we can be able to provide for the end users. And also we have a commodity, considerations around commodity. A proper planning that ensures that the right commodities come in and these products have the appropriate quality tests in accordance with the policy. So policy is also key. Like my colleague, Mrs. Dada said, in Nigeria, we didn't have a problem with policy around blood-based testing because the same policies that we supported the oral-based testing we leverage upon for the blood-based testing. So really important that we ensure that there's proper policy backing. And of course, with respect to the ethical consideration, it's really key also to ensure that we have the appropriate ethical clearances from the government agencies. So we also realized that for stakeholder engagements and advocacies, all through the process of planning, starting an intervention for HIV self-testing and implementation to the rollout, we carry out proper advocacies, carry out proper stakeholders, all the stakeholders from the community, private sector, the government, the end users. And the key here is end users. That has been for us. We've seen that if you focus a lot on the end users, it will help you to be able to have a proper plan. Then we have trainings. We have a lot of trainings, capacity building that were conducted, moderated by the Ministry of Health, and these trainings were conducted by partners, by the funder. Really important. Then we have demand creation. We had a robust demand creation plan that involves, of course, utilizing the proper marketing mix principles, product prices, and all that. We ensure that the right messaging, proper messaging, was being delivered to the end users. And messaging, we leverage on the mass media, we leverage on IEC materials, we leverage on the private sector. The private sector, the role of the private sector is also very key in planning the large-scale broad-based testing, because we realize that demand-side financing, demand-driven financing is really important and key for us to be able to plan. In Nigeria, for instance, a lot of persons that patronize they visit the private pharmacies for their medications, right? So we ensure that we realize the need to be able to leverage on that system, that private system, to drive financing for blood-based testing. And of course, we have the client feedback mechanism is also very key for us to be able to ensure a robust implementation for blood-based testing. So this alongside putting in place a very strong monitoring and evaluation process throughout the implementation will help to be able to have a robust implementation.
Thank you very much for these perspectives. I have just one perhaps follow-on question, and then I would like to open it up to the audience as well to ask their question. Please prepare your questions. I'm asking one last question because we touched on a very important point: supply chain, forecasting, quantification. Mr. Tassi, can you speak about this especially? Also from the perspective of how we have handled this for the Global Fund investment, because you know that Uganda and Tanzania, the Global Fund procurement for the next Global Fund round is really quite intense, was also already under MNF3, two of the countries with the highest number of test kit procurement. How have you handled, and what were the parameters on your decisions to order these test kits, procurement, supply chain, as well as the forecasting tool that you used for this large investment? Thank you.
Thank you very much. So maybe one thing I didn't mention was that prior to introducing the blood-based products, we also did a couple of assessments. We did landscape assessments, market researches, and one of the things that came out profoundly was that most of the people were willing to pay between $1 and $2 for the kits. That's the willingness to pay bit for the private sector. So that was also very important to inform our decision to ensure that more kits are available in the private sector, like I already mentioned about the fake ones. Now, in terms of forecasting, supply chain, planning, resource mobilization, so again, in one of the assessments, we also asked people about the choices, blood versus oral. It did not come out clear at that time, and we did not even have any country to benchmark with. So we made a decision to do the split of 30-40, 30-70. Yeah, 30 blood-based and then 70 oral. So we did the procurements and so we made sure that all the logistics planning, the tools, the requisition tools have both the blood-based and then the oral kits. So we've been procuring 70 oral and then 30 blood-based, be it Global Fund, be it PEPFAR. That's what we've been doing for the last couple of years. Now, surprisingly, the demand for both actually keeps increasing, both in the private sector and also in the public sector. So the demand for both blood-based and also oral keep increasing. At this point, one thing we want to do probably is just to integrate or have a component of implementation science, so that as we give people the products, as we distribute, as we continue working, as we do our HCD, but also need to do a bit of implementation science. What are the people saying? Is the split, this ratio of 30-70, is it changing in any way? Which products are they consuming most, and which populations are consuming what? Because we did a study, a pilot. We did a pilot with the Abbott kit, the Check Now, with university students. They donated some kits, and we tried it out with university students in a campaign. So within about a month, I think we had given out about 5,000 kits, and The university students, of course, were excited. This is a product they've never seen. Some of them were testing for HIV for the very first time. We're like, okay. And in our programming, university has not been one of the priority. We look more to adolescents out of school, in the community. Anyway, that's story for another day. So I think we need to be deliberate, do a bit of implementation science, ask more questions to inform our choices, to inform our decisions in terms of adaptation, but also in terms of rollout, because you also don't want a situation whereby you bring products and people are not using them. Yeah, so I think really each country needs to do a bit of assessment, assess your people, assess your the recipients of care, people who are going to use the kits, the users. What are their thoughts? What are they saying? What proportion probably is able to bring to themselves? Yeah, so that's it for now. We are still doing 30, 70, Global Fund, as well as PEPFAR, as well as Government of Uganda procurements. So that has been the split. Of course, save for the other the catalytic procurements like the staff procurement of Milan, that was a special one, and check now from Abbott, that was also a special one. So those, of course, come to do studies, come to do particular interventions. So the 37 doesn't apply because you're just looking at this product, you want to pilot it, you want demand financing and see how it plays out. Because even for the Milan kit, actually, the plateau was at about $2. Yeah, with demand financing, you start low, then you keep increasing. So the plateau was at about $2. And I think that's fundamental, especially in terms of decision making, in terms of supply chain planning, people planning their procurements in terms of which product to buy and for who, But also very, very, very importantly, I think the managers might do your supply chain training very well. Like I said, you need the implementation task, but also you need from time to time do supervision, do mentorships, listen to both the health care workers, the distributors in the community, but as well the users. Yeah, just know what's happening.
Thanks so much. So the question is more the price of the test, how many we can actually procure for that same price in terms of volumes, and then also to have really a choice. Have a choice between blood-based products and oil fluid products. But as we have heard from both countries, from the representatives, there's currently not really a choice, or both blood-based and oil fluid tests were introduced at the same time, which made the a choice open for the people who to access these products, and the questions of preferences actually not being provided. People have the choice between both, and people are either taking up the blood-based products because they already know that blood-based products are used for conventional testing, which we've heard from the example here mentioned. So I think that's very good examples of both products being introduced in the market. I would like to open it up for the last 5 minutes, perhaps to the audience to also ask questions. I think that you're burning for questions. We have the mic. Please stand up and perhaps introduce yourself and then ask your question. Thank you.
Thank you. Dr. Donobles from PSI Burundi. Were you taught about monitoring and evaluation? Well, my question is this: how do you manage to collect data from unassisted self-tests and self-tests which are distributed in which are sold in private pharmacies? Because we have a problem, we have a challenge in collecting data from unassisted self-tests, and we are looking forward to working with the private sector in the coming years. Thank you very much.
Wait, one more question, and then we perhaps go back to the
Thank you.
Thank you.
My name is Ombeni Werinde from Unitate, and great to hear the experiences across the countries. My question is, it seems like at the moment, most of the uptake is driven from push by the providers. Do we need to get to a stage where there is a pull from the population itself, the same as we have with pregnancy tests, where the population feels compelled to go and demand rather than the uptake being from the provider push to the population?
Okay, I think we take these first two questions. I think the first question will be actually addressed in the next session. That is at 12:05 in that same room. But if we perhaps have somebody who wants to respond to this, Mr. Tassi or yep, over here.
Maybe the issue of the pull and then push. For the public sector, like I did mention, for us, we did 30/70. All the products are already part of the ordering tools. So when the facility is ordering, they will place in their order, and of course it's auto in the system that if you're ordering for HIV self-tests, then the split is 30/70. So what we've seen actually is that the demand is overwhelming. So currently what the national medical stores and the joint medical stores issued the facilities. Of course, you issue depending on the order that has come, but the demand is overwhelming in the facilities. So it's no longer really a matter of push. At first, we had to ration the kits because we had limited kits. But as time went on, it's now full. So people are pulling, people are demanding. People want the facilities and the kits are not there. Because what we've done, we've given targets. These kits are not for everybody in the public sector. We have adolescents, we have key populations, we have the antenatal secondary distribution, and men, the men that you talked about. So they are not for everyone. But people in the general population, everybody comes and wants a self-test kit. So the advantage is that for the private sector, it's as well, I can call it pull as well, because as the demand increases, then the distributor also increase supply in the private sector. Yeah, so that's how the market is playing out, private and public.
Joseph, you will want to respond perhaps to the first question on M&E?
All right, thank you so much. So that's a great question, because in Nigeria, under the Global Fund project, when we rolled out HIV self-testing in 2021, we actually had this challenge you are talking about with respect to unassisted. So what we did is that we went internally and reviewed our systems and to see how we could improve that. We brought about client cards that are duplicated. That's when the kit is distributed, whether assisted or unassisted. We ensure that the different service delivery points, either in the private or in the community, are able to retain copies of these cards and give to the clients that is either purchasing or is being provided with these test kits. Now, what we did was we realized that we tried to follow up to ensure this return of these results was facilitated. But we realized there was a little hitch. We now started a kind of an incentivized system that utilize vouchers for clients that return the results. And I'm glad to tell you that we, as at September this year, we recorded over 90% return rate. Yes, over 90% return rate of the kits. And that we presented at a couple of fora that the Global Fund mediated. So it's really important to evaluate the system, look at the different